At that time, there's not so much population-based data on glaucoma. So there's only one study published in the Chinese journal report glaucoma prevalence in the Chinese population. Actually, if you look at the elderly population, 50 years and older, most of the cases identified in the population-based study, they're all primary angle kosher glaucoma cases, and only one case identified as open angle. At almost the same period of time, the Japanese National Survey published their prevalence of glaucoma. They report primary open angle glaucoma, in particular, the normal tension glaucoma. They're very common, like at least 2%, but very few primary angle kosher glaucoma. And then I start to ask myself, that these two populations, they're so close to each other. Why this disease spectrum is so different? Is it because of the methodology problem difference, or is it really because of the genetic background? Then I start to plan a study, a population-based study on prevalence of population-based study on glaucoma in we call it old town of Guangzhou, like, because where this is the population very stable. And then I start with three gentlemen. At that time, we are all a little bit like older than 30 years old. I worked with Tin Ong in Singapore, and also David Friedman and at Hopkins that time, and Paul Foster and UCL Moorfields. So after a couple of years, this we all grow up or get older, and Tin Ong is chairing the series in Singapore, and David Friedman is Harvard, and Paul Foster still in UK. But then we start to run a study, we call it Li1 Eye study. So this is really the first study, not a big sample size, about 1,400 people. But then we decide to use use the gonioscopy, examining every single participant in the study. And also we use Pentacam, anterior seminal CT, a lot of imaging facility, modality or equipments. And also we test visual field for the participant. So based on this a bit more reliable diagnostic criteria, we report the primary angle kosher glaucoma in this urban Chinese population is actually 2.1%. And primary angle kosher is 1.4. This is actually a little bit closer to what has been reported in the Japanese population. Then more interestingly, we also conduct similar study in Singapore and Mongolia. So when you look at this Mongolo-Chinese population, the disease spectrum is actually strikingly similar when the same methodology is used. So for example, primary angle kosher suspect, primary angle kosher glaucoma, it's almost similar, very similar, 6% angle kosher suspect, 2% primary angle kosher, but then only about around 1% people develop glaucomatic optic neuropathy. So, but at that time, because everybody understand angle kosher glaucoma is more a problem of anterior segment of your eyes. Then at that time, Zeiss just released the anterior segment Vicente OCT, but the automatic software is not available. Then we decide to develop a fully automatic software that allows us to, once you point out the scleral spur, so the software is able to delineate the boundary of the cornea, and also the anterior posterior surface of the iris, and also then give you all these parameters automatically. We call it Zhongshan Angle Assessment Program. So, and then we get it published, and then we release this software for free use to be used like free of charge to any researchers. So this software has been widely used in Singapore and UK, US, and Korea. There's been created more than 300 papers, and people using this will prove not just the mechanism of angle kosher, but they also use this software to image the cornea for new cornea surgery and so on. So angle kosher is traditionally be understood it as a pupil-brought mechanism or non-pupil-brought mechanism. So, but then laser peripheral iridotomy, laser PI is one of the methods of clinical surgical treatment that we move by making a hole on the iris that you can balance the pressure on the anterior chamber and the posterior chamber, and therefore flattening the iris and open angle. but then we're not quite sure who will need this iridotomy, because the challenge is really in China, 6 to 10% of the elderly, 50 years and older, they have angle closure suspect. So we are talking about 28 million of people with PACS. And then in USA and also UK, a lot of laser PI actually performed for prophylactic purpose. So, but then after the laser PI, a lot of people may have cataract progression and some, or perhaps have some damage on their corneal endothelium. So should we laser all of them? This is really a huge task, but then we're not quite sure in a long-term perspective whether this efficacy and safety is justified. So then we start to look at the short-term response to laser PI. We use this Li-1 eye study as an opportunity. We enroll a population-based primary angle closure suspect, and then we laser them. And then in 2 weeks, after 2 weeks of the laser, we examine the gonioscopy, but also the anterior segment imaging. And then we kind of prove that after the laser PI, in a short term, like 2 weeks time, actually the laser PI is able to open 80% of the angle based on UBM. But then we also identified there's a lot of anatomic feature. For example, the anterior rotation of the ciliary body, and also we call it peripheral last iris row. All these contribute to we call it non-response or not to the patients who do not respond to laser PI. But then something we're not able to prove is in a long period of time, like after maybe 6 or 10 years, what happened for these angle closure suspect eyes. So we decided to run a long-term study. We call it Zhongshan Angle Closure Prevention Trial to kind of prove the efficacy and safety of the prophylactic laser PI. But then we also try to observe, because we keep one eye treated, another eye untreated. We hope we're able to identify natural history and hopefully identify if there's any predictor for the conversion from primary angle closure suspect to primary angle closure. The study is straightforward. We actually screen more than 10,000 people in the community, and then we identify people with bio-natural primary angle closure suspect by gonioscopy, and then we randomized one eye to treatment, laser PI, and the fellow eye for observation. And then this is again a long-term study. We visit them at 2 weeks, 6 months, 18 months, 36 months until 6 years. So because in China we are able to manage these patients' compliance quite well by organizing some we call it patient or participant engagement workshop or symposium. So we actually, the retention rate even in this 6-year study is quite good. It says 75% of people, they stay in the study until the end to 6 years. So in this study we proved that after 6 years the laser PI is really able to reduce the risk of developing primary angle closure. But then the challenge is the incidence rate of the outcome is very low. And then a lot of these events, is just very mild in terms of like only develop PAS, primary anterior synechia only. There's very few patients develop acute attack. So the benefit of the prophylactic laser PI is limited. We therefore recommend widespread prophylactic laser PI. For this angle closure suspect is not recommended. And then after this paper published in Lancet, it really changed the clinical practice quite a bit. But then sometimes it goes too far. But most of the time, people now they tend to stay observe the patient rather than just operate or laser them immediately for the primary angle closure suspect. But some practice or some clinicians go a little bit too far because they're very confused on primary angle closure suspect, because some of the clinicians actually stop performing laser PI on the fellow eye of the acute attack. So this is to us, this is not really what we want to see. So we decide to give a couple of lectures and trying to make sure people understand what's the correct implication of this clinical trial.